Good morning, everyone. Welcome you to this new medical college and your new journey has already begun. I am Dr. Abhishek Chakraborty. I am MD Medicine from AGMC and GBB Hospital. I have recently joined here as an assistant professor in general medicine. So today, after Sir has taken such a beautiful and informative theoretical class, so you have understood lots of things now. You have understood about the pathophysiology first of all, the etiology, pathophysiology, something about clinical features, something about how to diagnose, that is the investigation, but not about treatment purpose still. So as the time will go, you will understand some more things about the anemia. There is mostly the clinical approach. Now after your 4.5 years of this journey, you will be going to hospital. So your final job is to diagnose and treat the patient. This is your job which is accepted by the society. So now, after this theoretical class, we will progress further towards the clinical approach, or you can say a clinical combination with physiology, pathology, as well as some part of diagnostic and treatment. That is the pure medicine. So normally, what we see that anemia is a highly prevalent disease. It's very common in our society, especially in the South Asian population or South Asian countries. What do you mean by South Asian? It's like India, Pakistan, Bangladesh, Nepal, Sri Lanka. These all areas are basically the South Asian countries where the prevalence is too high. It's near about 150 millions or 200 millions per year is the prevalence of anemia. Now, when we talk about anemia, as Sir has said, there are lots of kinds of anemias are there. There is a separate classification is there through which we diagnose the anemia based on morphology, etiology. These are the defined classification as Sir has told. I think we have noted also. So now in our case, we'll just imagine. You have not started your clinical class. You will start it from your second year. While you will be going to clinics, you will be doing the different type of examination. You will directly get attached with the patients, and their clinical doctors will be treating you all those things. But today, as a part of NMC, there is this technique has come that to combine the first year physiology, biochemistry, anatomy with clinical approach also. But in our time, we used to learn all these things usually from third semester or fourth semester. We used to go to our hospital and then we started to learn. So the thing is that it's a little bit complicated, not so easy, frankly speaking. At your level, you will understand basics, and then gradually you will understand the complicated modes, all these defined methods of diagnosis, defined modes of anemias are there. Even in the microcytic hypochromic, there are another 4 kinds of anemias are there. So there are defined classifications are there on the basis of proliferation. You have not studied about reticulocyte count. This based on proliferation, again there is another classification is there. But we will not go there now. So first of all, we'll imagine that you are sitting in a hospital, you are doing an emergency duty or maybe an OPD duty at around evening time. Okay, so you are the medical officer, simple medical officer. So now there, you see a patient came through an ambulance from some peripheral parts. Now, as I have said, the South Asian population are mostly poor socioeconomic status. And the anemia is very common in this group of people. From the low socioeconomic status, mostly, not all, but most of the cases belongs to that group, because out of all kinds, nutritional anemia, which Sir has said, is one of the most important cause of anemias. Now here you can see, this is the first case one, a 25-year-old woman is seen for easy fatigue for many months. So the main term is the easy fatigue or fatigability. So what do you mean by fatigability? This is a clinical term, of course. So fatigability means weakness. You're getting early weakness. Just after waking from sleep, you are always healthy, you are fit, you are ready to do all those your daily works. You may go for gym or you're doing something. But you're finding that, no, after rising from sleep, I'm again lethargic. I'm not fit to do all those routine activities. I want to sleep more for long time. This is one of the presentation you can see in the case of anemia. So this is the fatigability or fatigue, easy fatigue. Now, sometimes even after doing hard work, like you, after doing 9 to 5 classes, you may feel fatigue. This is physiological. But if you are feeling the fatigue since early in the morning or without doing much hard work, then this is a pathological sign. Okay? So, it's seen for easy fatigue for many months. Now, what is the main thing is that she is now 24 weeks pregnant. 24 weeks pregnant. Okay, so pregnancy is divided in weeks, we all know, but you will gradually learn. There is like 36 to 40 weeks period is there, which in terms in normal language you say there is a 9 months period or like that. So she is in 24 weeks, and based on that the patient is presenting to you. So your diagnosis should be based on this type of parameters. So you have to keep in mind. So I am telling you in very slow mode, but when you are in the emergency, when you are in the OPD, in a few seconds you have to understand all these terms, and you have to already set up in mind, and you have to approach for the diagnosis. So clinical approach is to be created from this level, and by years and years of practice you will get that much easier. So this will help to diagnose you immediately by just listening few things only. Or you have to ask some leading question to the patient also, which will come later. That is called history taking. So she is 24 weeks pregnant with her third child in 3 years. Okay, so this is very common in our population, we all know. Like in the 21st century it has reduced. In Gen Z you will not see that, but in our past generations it is very much common that they are having multiple pregnancies, and even every year this type of pregnancies are, which are actually not allowed in medically. So she does not see any obstetrician, and she does not take any vitamins. Vitamins means in simple language, they will say in their local language. If I say in Bengali, they will bori khaisi na. Kunu bori khaisi na. Bori means tablets. Okay, so they have not visited to doctor. They have not taken any antenatal visit. Antenatal means before delivery. There are multiple level of doctors and patient interactions are there, which are called antenatal visits, which she has not taken, which is very important. This has been given importance by our government for antenatal visits to prevent all those kinds of diseases. So she does not see any obstetrician and does not take any vitamins. Now lately she has developed a test for eating ice. It is just simply patient's language. I am telling you history. History is in patient's language. They will say in Bengali, if I speak, that sir kichu khaile mukhe shad lage na, borofer moto lage. Means it's like numbness. When you take ice, you know how does it feel. So whatever she takes, whatever she eats, she doesn't feel anything. So this is a sign of anemia. This is also known as loss of taste, or we can also say it's a dysgeusia. These are specific clinical terms. Loss of taste or dysgeusia. 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 These are clinical terms. Okay. Since it is a clinical oriented class, that's why I'm taking all those terms. It will be a little bit difficult, but you try. Okay. So she has irritability, exercise intolerance, as well as palpitation. Okay, so irritability. So she also complains about irritability. What is irritability? Like she is not comfortable with any work. She cannot concentrate. She argues with her husband. She argues with the family member. So she is already irritated. Exercise intolerance. Same, almost like fatigability. That after doing little bit of work, she feels tired. She is not cope up with the day-to-day life activities. Like in village areas, they usually they are actually farmers. So they have to do the household works or agricultural works. But after a few time, they feel tired. So normally this is the exercise intolerance. Followed by palpitation. Another important symptom. It is a symptoms. So when we take history, there are two important things are there. One is the symptoms and one is the signs. Symptom is what patient will tell you. So it is in their language, and then you will modify them. What are the signs, are the findings which you will elicit, from the findings which will elicit from patient. These are called signs. So these are two important things: symptoms and signs. So in this case also, we are talking about symptoms now. Then you will go for signs also. So she is having palpitation. Now, second is the family history and past history are negative. Now I will be next talking about history taking. That time I will tell why the family history or past history, these are important. She does not smoke or drink. This is also a component of history taking. Physical examination is positive for some findings. I'm coming one by one. So when you are sitting in OPD or emergency, I have already told you to imagine that you are sitting there. So what is the basic approach to clinical case? Like this clinical case of anemia is the history taking. So history taking is very important for a doctor. Whatever your post is, whatever your degree is, as a basic doctor, you have to do the history taking. So what are the components of history taking? You have to know. So you notice, okay. So first is the patient's particulars. First heading is the patient's particulars. Patient particulars means you have to ask the name of the patient. Very important. You have to ask age, is another important thing, because as day by day we will learn more things. You will see that different diseases are prevalent in different age group, in different gender group. So you have to ask what is the age of that patient. Like for example, I am giving, as you have already know, the some terms about anemia. For an elderly patient, there is high chance that he is suffering from megaloblastic anemia. In a young patient, like in this pregnancy case, there is more chance she is having iron deficiency anemia, because it's depend upon diet. It will be coming later when we'll talk about the different etiology. So age-wise, the etiology depends. The gender-wise, the etiology depends. So patient's particular, followed by age, followed by gender. Then next what? Even religion is also important. Even religion is important because in defined communities, it has been found that defined diseases are more prevalent. And that by that way, you have to interlink all these things. So that's why the religion is important. Fifth, address. From which geological area he or she belongs. This is another important thing. For example, I'm giving you, in states like Odisha, Bihar, Chhattisgarh, West Bengal, in all these areas, anyone from these places? Okay, so from these areas, you will find that sickle cell anemia is very common. You have studied sickle cell anemia, sir has said already. This sickle cell anemia, you have also told about the pathophysiology, genetic pathology you have said, so you know. So this sickle cell anemia is very common from these areas. Again, there is northeastern states. In northeastern states, you will get thalassemia is more common. So this is the importance of geographical, the address of the patient which you will be asking. Then occupation. Another important thing is occupation. Okay, so these are the important things in the components of the patient's particular. You will be asking that patient while you are attending that anemia patient as a part of approach. Followed by that, you will go to complaint, chief complaint. Chief complaint means what patient is telling you. That symptom, I have already said the symptom, it will be written in the form of chief complaint. So chief complaint, here you can see that patient is saying that she is having exercise intolerance. It's actually not a clear presentation. She will say that sir khub durbal lage. In Bengali you say khub durbal lage means she's tired, easy tired. So from that you have to understand that she is having either easy fatigability, exercise, and all these terms will come. But actually it means that durbalata. This is the most common presentation you can see in the case of anemia. Second, she will say that palpitation. In palpitation in Bengali, what will they say? Because since you will pass another 5.5 years in Tripura, so you will be taking history little by little in medical college in Bengali also. So you have to understand those terms. So they will say that palpitation in the form of বুক ধরফর করে. This is the common language. This is the common language patient will tell you whenever you are attending in emergency or in the ward or in the OPDs. Okay, so these are the terms they will tell in when they're presenting the cause of anemia. That time your mind should strike, oh, this can be a case of anemia, so I should progress in this way. So chief complaint will be like this. So do not write chief complaint more than 2 or 3, and most importantly you have to write the duration. Here the duration is actually not specifically written, but you should know that when you are writing all those symptoms, you should write the duration also, like for last 1 month, like last for 20 days. So duration is also a part of chief complaint along with the symptom. Okay, then comes the major part, which is the history of presenting illness. This is much more complicated part. I'll not tell you all those things because you are just in first year, but you understand that what are the chief complaints they have said. It is the patient's own language. Okay, they have said their own, that I am suffering from this. Now you have to elicit the other things also, because palpitation and weakness can be seen in heart disease, can be seen in lungs disease. So you are not sure that it is only anemia. From these two, you will not be 100% sure that it is a case of anemia. So you have to approach further. So for that, you have that is the history of presenting illness, which is the third component here. So in history of presenting illness, you will elicit much more things. This is the third component. After that, what will be there? It is the past history. From past history only, we have come to know that she is already having third child in 3 years. So this is very much abnormal. Okay, so this will have very much effect on mother's nutrition. It will have very deleterious effect on the baby's nutrition. So all those combined, and blood loss. Once the blood loss is there, if you see the normal level of blood loss, it is, as per WHO, it is in normal delivery, it is up to 500 ml. If cesarean, up to 1 liter. So 1 liter and 500 ml is considered normal in this case. But after pregnancy, we have to modify it. Patient should come to normal range, and that will take another 1 year. But before that only she is again pregnant, and her demand is increasing because she is having fetus or baby in her womb, and the blood requirement is increased. This is the basic pathophysiology, simply pathophysiology, which is working here. It is the increased demand from fetus and increased blood loss from mother. Both has resulted in anemia. What type of anemia we'll discuss later. So first of all, we are getting that this is the overall history, and that's why past history is important. Along with past history, we have to ask whether patient is having other clinical disorders there or not. We have to ask whether the patient having diabetes, whether patient having thyroid illness, whether patient is suffering from any chronic infections. So all these will be asked in the past history. This is another important thing in the clinical history. After that, important is the family history. So why family history is important? Family history is important because those thalassemia, okay, they can run in family. Then coagulation disorder, what sir has said, that hemophilia, they can run in family. So all these hereditary cause of anemia, which are also known as hereditary hemoglobinopathies, sickle cell and thalassemia, they too can run in their race or family. Both can occur. Race is like in the Jharkhand area, there is tribal population. They are the particular race, and among them the disease is prevalent. So this is the importance. So that's why family history is very important. Okay, as well as addiction history is also important. Alcohol is very common. Both male and female can take alcohol, and as sir has already shown you, alcohol is one of the important cause of which type of anemia? Sir has shown you alcohol can cause mostly megaloblastic anemia, as well as it can be some nutritional deficiency, because chronic alcoholics, they are not taking proper diet, so they can have nutritional anemia also, as well as there is megaloblastic anemia also. It's a pathogenesis is there. So this is the importance in this case where we are going for some clinical approach. So up to, we have seen the patient particulars, then we have seen the chief complaint, history of presenting illness, past history, family history, addiction history. These are the main components. Social history and all these things are also there, but it will be that not much important. Now, after that, most important thing is the examination of the patient. Clinical examination of patient is very important. Whenever you get a patient, whatever said that in the OPD, ward, emergency, you are approaching a patient, you have to do some basic examination. Now, basic examinations can be again divided into routine examination with vitals, and there are some specific investigations also. So, in this case, she is a obstetric mother. She is in pregnant state. Now, you are a general physician. You are just an MBBS. So, obstetric examination is defined part, but before that, you will go for general examination. Simple term, general examination. In general examination, you will overall check the patient whether she is conscious or not. What is the level? What do you mean by consciousness? Consciousness? Anybody? Consciousness means you are attached to the environment. What is happening in the environment? You are oriented or you are aware of the surrounding environment. This is called consciousness level. How we measure the consciousness? It's separate. We will not go that far. Second is the orientation also. We have to look for. Orientation means whether the patient is oriented or she knows about who is she, what is the present time, it is a day or night, or whether it is what is the place of the now she is present, or what is the with whom she has come. So these are very important to monitor the patient's CNS function. CNS means central nervous system. How much her brain is working properly. In multiple cause, it can suppress, the activity can be suppressed. Even in anemia also, severe anemia also, patient can get disoriented due to multiple, because hypoxia is one of the factors that sir has already told you. So these are the factors can result in loss of consciousness or disorientation. These are the pathological finding of normal finding. Okay, loss of consciousness or disorientation. Third, you have to look for patient is febrile or not. Febrile means fever. Fever is present or not. These are the common findings we have to write. Whatever, it can be negative also. So in this case, there may not be fever. But when you do the clinical examination, routinely we write that fever, no. Okay, conscious, yes. Oriented, yes. Like this, we have to write the findings. Then comes your normal vitals. What are the vitals? What are the components in vitals? Vitals involve blood pressure, pulse rate, your oxygen saturation. Okay, so these are the components in the vitals which you have to write here. Respiratory rate is also included here. These are the findings in general examination among the vitals. Okay. Then comes your some specific other finding, local findings are also there. For example, one by one we'll say there is the first is pallor. Pallor means paleness. Now in anemia, what is the basic defect? What is the basic defect in anemia? Hemoglobin is less. Simple definition. It is either in the terms of hemoglobin or in terms of RBC mass. So here, hemoglobin is less. So automatically, the blood which is going to your tissues, through your different blood vessels, whatever arteries, veins, capillaries, the blood flow to your peripheral tissues, different at the end of the tissues are less. So for behind that pathophysiology, we use this one to find the sign of anemia. Now, whenever a patient says that weakness and all, these are patient's symptom. But we have said that there will be some signs or some findings which we will do to elicit patient having anemia. Okay. So what we'll do? We'll check the pallor or paleness. Now, most important thing, how to check pallor? Okay. So anybody knows how to check pallor? Which site? Exact name the site. Which one? Eyes. Okay. Okay. Eyes. Any other site you can check? Huh? Nails. Nails. Or you want to say nail bed. Any other side? Any other side where you have proper mucosa? Tongue or buccal cavity. And another important area is there. Nose. No, nose, not nose. Any other side? Palmar crease. This palmar crease is also an important area where you should check for pallor. So these are the common areas. So you can practice with one another. You check your friends that eye, or this is the specific term is bulbar conjunctiva. You check each other's, then you can diagnose it whether anybody is having pallor or not. So you can diagnose the anemia by simply. Now, it is a proper checking is like you should stand in front or you sit in front by using your both the hands. You will just retract. Okay, then you can see the bulbar conjunctiva easily. Just simply and ask the patient to look above, then you can see the bulbar conjunctiva. Okay, so this will be gradually with practice you can learn. Similarly, you can check the buccal cavity or tongue because they are also mucosa. There is blood supply will be less, so automatically the color will change. Palmar crease is there. Palmar crease is very important. There is an important limit is there. Like if palmar crease is whiter or similar color to your palm, skin of the palm, it means that hemoglobin is less than 7. Okay, it means that hemoglobin is less than 7 gram per deciliter. It is a clinical correlation. This is one of the important markers. So this is the pallor you should check for anemia. Now, when you find that patient having pallor and you are suspecting that you are almost sure that yes, this patient having anemia, you should search for other important findings also. Other clinical signs are also there. What are the other clinical signs you can expect? Fatigue. No, you are any other sign in mucosa or skin, in nails, spoon-shaped nails or spooning of nails. What is no smooth tongue? It is also known as, what are the clinical terms? What is the clinical term for this spooning of nails? Anybody? Coelonicia. What about the tongue? You have said that the tongue surface is smooth. There is no papillae. Papillae are damaged. What is there? Anybody from last? Atrophy of tongue. Okay. This is also called glossitis. Then any other thing in the angle of the mouth? In the angle of mouth, any change? I have one photo here. So you can see there, like these things. This is called? No. This is called? You can say angular stomatitis or you can say cheilosis. These are the terms. Okay. This is the finding here. Angular stomatitis or cheilosis. This is the spooning of nails or coelonychia. This is the aphthous ulcer. It can occur because of other multivitamin deficiency also. So these are some of the specific findings. Though they are not that much common, you can search for all those things. Okay, these are more commonly found in nutritional deficiency. Actually, I am talking about iron deficiency anemia. You will find all those specific findings. Now, along with that, this clinical examination, we have said that pallor. After that, we have another important thing which you should notice, and it is also having some relation with anemia, some specific kinds of anemia. This is the icterus. Have you heard the term icterus? I-C-T-E-R-U-S. Icterus. Icterus means yellowish discoloration of sclera. Simple. In the sclera, there will be yellowish discoloration. It is seen in which condition? Jaundice. Jaundice means bilirubin more than 2 mg per deciliter. This is called jaundice. Now, jaundice has lots of causes. We'll not go to there. But you remember that jaundice can be associated with anemia, and these patients can present both pallor and both icterus. Very important. Both pallor and both icterus can be present together. These are mostly seen in case of chronic hemolytic anemias. For that, to understand that, you have to understand the hemoglobin and bilirubin metabolism. You will understand in your further classes where you will be taught about unconjugated, conjugated bilirubin and all those things. So when these topics will be covered, you can correlate each of this. Yes, clinically also. Because in case of hemolytic anemias, there is RBC destruction. So RBC destruction means hemoglobin is released in the blood, in the plasma, and this hemoglobin is metabolized. This hemoglobin is ultimately metabolized to produce bilirubin. There are different forms of bilirubin are there, unconjugated or indirect, conjugated or direct, and when their level rises, they results in jaundice. So up to this much you know now, later we will study all those things. So important is the checking for icterus also. Icterus in the yellowish discoloration, mostly found in the sclera. But jaundice can also be seen in normal skin, even in the tongue, upper surface of the tongue. So all these areas are also included when we check for jaundice. Now after that, there are some other things in this general examination. This involves cyanosis. Now how cyanosis can be related to anemia? Cyanosis, why does it develop? It is called bluish discoloration of skin and mucosa. It's called cyanosis. Cyanosis is seen in oxygen deficient states.
ডিসকাস করেছো সায়েন্স সিম্পটম দিয়ে ল্যাবরেটরি ইনভেস্টিগেশন করতে হবে, ল্যাবরেটরি ইনভেস্টিগেশন করে জোর দেবে বেশি, জানা ফিজিওলজি সায়েন্স তারা বুঝবে না এখন। আচ্ছা সংস্কার করবে।
So cyanosis is one of the important another finding, followed by we have the other findings also like lymphadenopathy, pediledema, but we will not go this. These are the clinical parts. We will grow gradually. We will be studying all those things. So followed by that, now this is the history part is over. Then your examination part is also over. Now we have to go for further diagnosis of this patient. Now for accurate diagnosis, we'll go to some laboratory causes, laboratory findings. So laboratory findings are important when you diagnose a case of anemia. Now what are the basic tests you will performing? Basic test will be performing is the routine blood test. We will advise for some routine blood tests. Among them, we have the complete blood count. It is called complete blood count with peripheral blood smear. Okay, so complete blood count. What are the components of complete blood count? Most importantly, what is required here is the hemoglobin. Okay, along with RBC count, along with hematocrit level. Esa has already told you all these are the components we have to check, and there are some normal limit also. Other than these three, there are also other things like total WBC count, platelet count, but we'll study later. So initially there is the hemoglobin. Now you know the normal level of hemoglobin. You tell me. Normal level for male, female. For male. Okay, and for female? Okay. Now for diagnosis of anemia, the WHO has given a simple criteria based on which we can say that patient is anemic. That is for adult male is less than 13 gram per deciliter. For an adult female, non-pregnant female is less than 12 gram per deciliter. And for a pregnant female, it is less than 11 gram per deciliter. So these are the three things in clinical approach. You should use them for easy diagnosis. So this is the based on hemoglobin, which is important. So hemoglobin will giving you the idea that it is the patient is having anemic based on your this finding. After that, you will further progress. In further progression, you will check the peripheral blood smear. Peripheral blood smear is the made by blood only. This is on the glass slide where you put the drop of blood and then we make a smear. We will be doing that in our physiology practical, and that time you will understand how to make a smear. In that smear, under microscope, we will see some major findings, and based on that, we will diagnose what is the kind of anemia that we have already said, whether it is normocytic normochromic, whether it is microcytic hypochromic or macrocytic. In theory class, we have already studied that. So based on that, we will diagnose that which group of anemia it is. So for microcytic, macrocytic, normocytic. Now, what are the values we use for defining these three? We have just before that half an hour before Sahar said, what are these? MCV, MCH, MCHC. These three, their normal level also being discussed. So based on these three only, we will be seeing whether what is the size of RBC. It is the mean corpuscular volume. Volume of RBC it has been described. 78 to 94, less than 70 macrocytic, more than 100 macrocytic. So this is the mean corpuscular volume. Similarly, their hemoglobin concentration also being determined. So based on these three values, we can diagnose what is the type of anemia: microcytic hypochromic, macrocytic, or normocytic normochromic. Okay. Followed by that, in peripheral blood smear, there is some abnormal findings will always also be seen in different types of anemia. But it is a pathological finding, so I will not discuss here. These are pathological findings we will see in the peripheral blood smear. So followed by that, we will do some other routine investigation in a pregnant, obviously. These are like thyroid profile, viral markers, all these things will be attached to anemia. That will be clinical approach different. Now, when we suspect that pregnant female, from history, from examination, and from their laboratory finding of doing the complete blood count, we found that she is having microcytic hypochromic type of anemia. Okay, so what we got? She is having microcytic hypochromic type of anemia. So now the pathologist will advise you that you should do some other specific tests. Some specific test has to be done for confirmation of your diagnosis. Okay, once you get CBC report, there it is the pathologist who will write that this is the finding, microcytic hypochromic type, and please correlate clinically and do the specific test. What is the specific test? It is the iron profile, as well as hemoglobin electrophoresis. It is defined issue. It is done for little bit complicated for diagnosis of thalassemia or sickle cell anemia. We perform hemoglobin electrophoresis. I will not discuss here. I will simply talk about iron profile. Why iron profile is done? Simple, to diagnose iron deficiency anemia. So we'll go for, this is the finding C in CBC in iron deficiency anemia. Hemoglobin, you will find the low. You will check for MCV will be low. MCH is still low. MCH is also low. WBC normal, platelet normal. Now these issues will be discussed later in the pathology class. I will not go. Reticulocyte count is also important. Reticulocyte count. This is an important. These are the immature nucleated RBCs are the retic count. Now they increases, they decreases in defined types of anemia. Okay. Now beyond that, we have the iron profile. So for diagnosis of iron deficiency anemia, we have to do the iron profile. When you get a picture of microcytic hypochromic anemia, so in that case, you will find that there are different parameters: serum iron, serum ferritin, total iron binding capacity, transferrin, saturation. Okay, so iron metabolism, you have understood how it is obtained from diet, it is absorbed, and then it is in circulation. It is circulated in a bound form with a protein called transferrin. It is stored in another protein called ferritin. In bone marrow, in liver, they are stored. So these are some components which are important in case of iron profile. All of these are actually measured. So simple thing, the iron deficiency anemia, you will check the serum iron, it is found to be reduced. Okay, so reduced in iron deficiency, almost less than 30 microgram per deciliter. You will check for ferritin level. Ferritin, what does the ferritin indicates? Ferritin indicates the storage of iron. So along iron deficiency anemia is not just lack of iron leading to anemia, but there is also depletion of stores of iron. So iron is stored in our body. When it is absorbed, followed by that is stored in bone marrow, in liver, etc. So this storage of iron occurs in form of ferritin, which is a protein, glycoprotein. So this ferritin will also get reduced, and it indicates that patient is depleted stores. We have to correct it. Similarly, we have the total iron binding capacity and transferrin saturation. Now transferrin is the one which will bind with the iron when the iron has been absorbed from your intestine to the circulation. And the iron will bind with the transferrin, they will circulate, they will go to the tissues. Now this transferrin saturation means how much iron has bound to the transferrin. This is the meaning in case of for what we mean by transferrin saturation. There is a pathological calculation is there, but simple language, you have transferrin, you have iron. Now the iron is less, so the binding of transferrin to the iron will be also less. So your transferrin saturation is reduced. Third thing is the total iron binding capacity of transferrin. Okay, it is the total iron binding capacity of transferrin to iron. Now when iron is less, so automatically your transferrin has more capacity to bind or more ability to bind. Okay, so this is the amount of transferrin in your body. This is the amount of iron because it has been reduced. So transferrin has lots of space for binding with iron. So automatically the transferrin, total iron binding capacity will increase, but the saturation level is reduced. Transferrin saturation is reduced because less iron has bound to it. Okay, so these are the parameters we check for iron deficiency anemia. This is the basic one. This is the diagnostic which will be used for, you will get commonly in laboratory, you will do the blood test from defined labs, you will get this type of reports. Now, when this is the differential diagnosis I have given for microcytic hypochromic anemia. Okay, so this is a microcytic hypochromic anemia what sir has told, and this patient was actually a case of microcytic hypochromia. Now in microcytic hypochromic anemia is not only iron deficiency. There are 4 different kinds of anemia is there in this group. These are sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic diseases. Okay, and the sir has shown the classification already. So these are the 4 anemias, but out of that, which is the most common is actually the iron deficiency anemia is more prevalent in our country, in our areas. So we have diagnosed the case from iron profile. It is showing that iron profile is diminished. All these parameters are diminished. Now in different entities of these diseases, this iron profile will be different. Okay, I have not shown all these parameters for different diseases. I have shown only the iron deficiency anemia. So the diagnosis is clear. There is a case of iron deficiency anemia of a pregnant woman. Now we will basically go for correction. Okay, so among the correction, what are the modes of treatment available? We have oral iron treatment, parenteral iron treatment, or even the blood transfusion. There is the pegged RBC, it's a different thing, it's blood transfusion. Now, in common practice, mostly we are giving oral iron. So those who are having usually mild anemia, we are usually giving more than 7 gram per deciliter, you are giving oral iron for correction. Now in oral iron, there are different forms of iron salts are available. These are like ferrous sulfate, ferrous ascorbate, ferrous fumarate. Other forms are also there which contain defined amount of that iron salt. But our aim is to give like 100 to 200 milligram of elemental iron daily, which will be absorbed in the intestine. Elemental iron. For example, ferrous sulfate, it's 60 milligram of ferrous sulfate is contain 100 milligram elemental iron. So this is the defined calculations, but it's not that important. So our aim is to give 100 to 200 milligram of elemental iron per day in form of tablets. Okay, so iron tablets are available. Iron tablets are given before food for better absorption. There are different factors which will impair the absorption of iron. So it will be, I will not go there. So you understand that we are giving that much dose, and our aim is to correct the anemia as well as to replenish the stores of iron. Those stores has depleted, so you have to correct the iron stores also. So the duration of treatment is almost 6 to 12 months. Now hemoglobin correction, rising of hemoglobin by about 0.8 to 1 gram per deciliter, you will start by another 2 to 3 weeks. But it doesn't mean that patient has been corrected. Patient symptoms will gradually decrease as the hemoglobin level rise, reticulocyte count rise. It will take if your target is like for 7 gram, your target is 12, then it will by another 12 weeks it will rise. By 3 months that hemoglobin level will rise. But your aim is the replenishment of store. For that another 3 months can be needed. So this is our aim. Second is the parenteral iron therapy, means by IV injection. We can also give. It is mostly given when the oral iron is not tolerated by the patient. What do you mean by tolerance? There is GI problem. Now iron is very cheap, very affordable, easily available, but they have adverse effects. Mostly GI adverse. GI means gastrointestinal. You will have nausea, you will have vomiting, constipation, metallic taste. These are the adverse effects. So you have to cope up with that. If patient cope up, then good. Otherwise, you have to go for parenteral therapy. Sometimes other issues are also, genetic issues are also there. Patient may not respond to oral iron therapy. That time also you have to go for parenteral iron therapy. So we have iron sucrose, iron dextran, iron carboxymaltose. These are first generation, second generation, third generation, modified versions, because initial versions, they cause allergic reactions. So as we go for generation, like dextran is first generation, followed by sucrose, second generation, carboxymaltose, third generation. They are much more improved. They cause less allergic reaction and better response also. So this is the one. Now how to calculate the dosing? This is important. When you give parenteral iron, you have to calculate the dosing. How much dose of iron you have to inject to the patient. For that, this formula is used. 2.2 into body weight in kg, normal hemoglobin, suppose 15, minus patient's hemoglobin, plus 1000. And these 1000 indicate the body store. You can give up to this level also, but the stores will not be repleted. If you add 1000 extra, it will be correcting the patient's store. So by decoding that amount, you will be giving the patient as an injection, as an infusion for a defined periods of time, and it will be corrected. Third is this RBC transfusion. It is given when the acute need is there, like patient is in delivery and her hemoglobin is 6. Patient is having less than 4, severe anemia. So in these cases, you have to go for blood transfusion or RBC transfusion. Okay, so this is the management. What I have taught about this iron deficiency anemia, which is the most common anemia. Okay, so this is the first discussion with you for a clinical approach, but later we'll talk more things. Okay, thank you.